yeah, you can go on to chair the session.
All right. Thank you. Thank you very much, Professor Olivier. I think my system conspired not to allow me the honor to invite you. I think it just realized you my co-chair for the various sessions. Professor Olivier, now that we have talked about the vaccine, I have found out currently here, if we have the Terraria vaccine, if you want to vaccinate one animal, it is actually impossible. You must vaccinate at least 100 at a go. So what is your take on the cost of the vaccine in this case? Thank you.
Gosh, that's a difficult question because what I remember from the Teleria parva vaccine in Kenya was it was a live vaccine, and that will depend on what vaccines we are using. And that could be the problem because there are pros and cons to use a live vaccine. The live vaccine will allow the immune system of the patient or the animal to face the pathogens for a longer time, and so to develop a more robust immune reactions. But the problem with a live vaccine is that you introduce the pathogens in your patient or your animals. And in this case, like we did in Kenya, we were injecting Teleria parva alive into the animals. So you can imagine that, as you said, if I only vaccinate one of the 10 cows and we still use drugs to make sure the Teleria parva was not multiplying too much in the cow, so it gives time to the cow, but we were not doing anything for the other cows. So as you said, if there is a tick feeding on my vaccinated animal, it's picking Teleria parva, doesn't get the drugs that the vaccinated cow was receiving to protect her, and this tick is now taking a Teleria parva from the farm and spread it to the rest of the farm by biting the other animals. So as you said, we work with this kind of live vaccine and introduce a pathogen in the farm. I think you have to vaccinate all the animals in the farms, or you take the risk that you only vaccinate some, and now you expose and take the risk that you introduce the pathogens in the farm, and those not vaccinated can be at risk that some ticks will pass these pathogens that was not there in the first place. And what we know with the live vaccine is that you have to be extremely careful how you balance the pathogens and the drugs to make sure if the drug is too strong, the pathogens will die and not proliferate, and then the immune system doesn't see anything. If the drug is not strong enough, then the pathogen is now surviving, proliferating, and the animal has no time to develop the immunity and they start to be sick. So I think what I see is that now people prefer to go into more recombinant and genetic vaccines because it doesn't bring these live pathogens into the farm. Having said that, and we have seen that with the tick vaccine, you have to be extremely careful. And we had this discussion with other colleagues here in the room, is that the pathogens you are picking in Kenya, we hope it's the same, the antigen and the protein you pick in Kenya, you hope it's the same protein that we have in the same ticks in Hong Kong, in Pakistan, or in Trinidad and Tobago. And we have seen with the tick vaccine that unfortunately, the BM86, 91, and 95 proteins were not worldwide prevalent in other countries. And unfortunately, the vaccine in Australia worked only in Australia because the ticks in South America didn't have this protein. They had mutated. They were the same species, but nevertheless, the vaccine was not recognizing the protein that had mutated in ticks from other countries. So once again, if somebody wants to put a tick vaccine on the market, make sure that whatever you target in terms of protein is going to be a protein that exists in all the ticks in all the countries, so you can sell your vaccine to every country and not just yours where you have been testing the vaccine. So so many companies, I'm very surprised there's still no vaccine on the market. Thanks for the question.
I was asking about the uptake of the vaccine. Now that we have seen apathy even in human vaccine, what do you see the future of the vaccine in the control of neglected diseases? Thank you.
Oh, gosh, if I knew the answer, I would be a rich man, but I'm not, I don't know the answer. But as we have seen, my worry is that when we are vaccinating against one disease, it doesn't prevent your patient to die from others. And that is why maybe a few years ago, a few decades, people decided to develop a mosquito vaccine, a tick vaccine, because they thought by eradicating and knocking down the ticks and the mosquitoes, you eradicate all the diseases they are carrying. If I just stop Teleria, I'm not going to prevent my cow to die from Ehrlichia, Anaplasma, and other viruses. So in a way, you could say, you were mentioning about the cost effectiveness. I guess it depends in which country we are working, where we know what is endemic and how many diseases are around, because now, if I was working in Kenya, I will not recommend a Teleria vaccine. I will recommend an anti-tick vaccines to make sure I remove the Anaplasma, the Ehrlichia, the Teleria, and the things that, like the Nairobi sheep disease, where in fact it's a toxin, but the toxin is because of the tick bite. So I could kill my Teleria, but your sheep still get the Nairobi sheep disease and they die of it. So I will go for the vector now. I will go for an anti-vector. If I stop one disease, it's maybe not enough now.
Thank you for the response. Let's hear the question from Lydia. Lydia, you're welcome.
Thank you, Josephine.
Kindly unmute.
Yeah. Thank you, Olivier, for a very exciting presentation. I just want to ask if these ticks are developing resistance to acaricides, the presently used acaricides.
Absolutely. I mean, we have done that with other countries in Europe, and we have seen a lot of acaricide resistance, and for different reasons. And although I know the talk is recorded, I have to be extremely careful what I'm going to say, because it could be on Twitter and YouTube tomorrow. So we know that in some countries there is a lack of drugs to be used against ticks and tick-borne diseases. And if you are a medic and a veterinarian in some countries and you face your patients being affected and dying, sometimes you have no other choice than to try other drugs that are maybe not licensed for what they are licensed in your country. And I know sometimes practitioners have no other options that to try other drugs that they think maybe if it works on the mites, maybe it will work on the ticks. If it works on the mosquitoes, maybe, but they have no proper tick license for this kind of drugs. So they have to try other things. And that is why sometimes we have this resistance, because we can't use what we want to use. But the other thing I've seen is that sometimes we need also to educate the general public and the farmers, because I have seen many times farmers trying to dilute the drugs we give them because they think it's cheaper. And if I can dilute the drugs, then I can use it on a longer term and it costs me less. But in fact, you're just exposing your ticks or your mosquitoes or your parasite or your virus to a lower dose, and you give them time to adapt to these lower doses. And in this case, you create the resistance on your own farms and in your own family by not following the guidelines of what are the real dose that will eradicate and kill these ectoparasite or endoparasite. So sometimes I see the problem of resistance is created by ourselves and the farmers and the vet and the medics and ourselves not using the right dose and exposing these pathogens to lower dose. That's not good. It gives them time to adapt. And we don't want that. We need to kill fast.
Thank you, Olivier.
Thank you very much for that response, Professor Olivier and Lydia, for the question. Do we have any other question? You can unmute and ask. I cannot see any raised hand for now.
Josephine, I heard about the speeches of Lydia and Professor Sparagano, and they raised the impact of COVID on the vector management. So I would like to raise this topic for you. Could you please share your opinions about the impacts of COVID on the neglected tropic diseases management or the vector management for us? Thank you.
Who wants to start? What I see here is that we had a few issues. Because of the COVID, we had a breakdown sometime in the circulation of drugs that were not coming to the countries where we wanted to treat the animals or treat the patients, because flights were canceled, everything was canceled, you could not import the drugs you wanted, and people were not able to treat, practitioners could not find the drugs they wanted to use to treat their patients, being animals or humans. So we had this first problem because of borders being closed and flight being closed and nothing moving between countries. That is the first problem. Now, as I showed with the Borrelia, there is a lot of second thoughts that maybe we have just started to understand what COVID has done. And it could be socially, because we have seen a lot of differences between the attitude of people towards vaccination, towards drugs, towards working at home, going out, and that of course changed completely the situation in terms of public health, exposure, interactions with a broader spectrum of people. If you work alone at home and you don't go out, then you encounter less problems with other people, but suddenly you're not exposed to anything, you have not access to the medical care you need. We saw a lot of people, we were in quarantine in some countries, not being able to go for their surgery, not going to be able to for their treatment in hospitals because it was not allowed to leave your home, and so they could not anymore continue to treat diabetes or whatever issues. So there is a huge problems that maybe COVID was just the tip of the iceberg to test our resilience in terms of drug production, drug circulation, social interactions. And I'm asking more questions than I'm giving you answer, and I'm sorry for that, but it's maybe because we need to reflect on that. And I think COVID has something that creating a global problem that we were not facing and we did not expect, and we have to learn from it. So as Josephine was saying at one stage, when the COVID situation will regulate better and we will start to analyze the data, and if people who were infected have secondary infection we didn't know about, if there was some issue in hospitalization we did not have time to test at that time, maybe we will know all the interaction between the COVID and the rest. And we know, like many viruses, they are mutating, and this is what we are changing our vaccines on a yearly basis for the flu, and we ask people to be vaccinated for the COVID, and some countries are now moving to the 4th and the 5th jab for the COVID. So we know they are mutating, and we need to be prepared also to adapt, that whatever treatment or vaccine we put this year on the market can be completely useless next year because our targeted pathogens have mutated. And we need to find a system that can be flexible but fast response to make sure whatever we face next time, we are ready to move with something that can treat not just for a few months, but give a long-term protection. And we are not there yet, and we know that with the flu, and we know that with the COVID. So I think it was a warning for us that we are not protected for life, and we need maybe to work on that. So once again, I don't give you any answer. I just create more questions and problems, but that's what we are facing, all of us.
Thank you, Olivier. And Lydia, may I know your opinions about this question?
You're asking Lydia? Yeah.
Yeah.
Are you asking me?
Yeah.
Yeah, of course, COVID, from my presentation, COVID really had a very big impact on particularly the NTDs, because most of the services were really stopped. The regular services such as the mass drug administration particularly. So I believe that the prevalence would have gone up, and especially the resources have all been like, there was such a thing as COVIDization. So the person, all the resources have been repurposed, and even the personnel. So I think there's a lot of setback that has happened as a result of COVID, and we need to do a lot to catch up with the whatever gains we have in before COVID. We should be able to regain this, and there's a lot of catching up that we have to do. Thank you.
Thank you, Lydia.
If I might add, only We are also going through now some reports about what we call the long COVID syndromes, where people who got COVID now are keeping long-term side effects. And we are not yet understanding what's happening, or if it's going to be a long-term problem for their respiratory tract, if they are going to be more susceptible to future infections. There is this population of people who have maybe not been treated or have been exposed to different kind of COVID mutants and have carrying this kind of debilitating syndromes. What is going to happen to them on the long term? People who have been vaccinated and are reacting well is one thing, but there is a lot of people who have not been vaccinated who are carrying the COVID for a long term, and we don't know how that is affecting them on the long run. And so there is maybe something to do as well on these long COVID syndrome patients.
Thank you, Olivier. Thank you for your insight. Josephine, as the second speaker, Julia has not arrived yet, so I think
Yes.
we can conclude the third session.
Yes, we can actually conclude. And before we conclude, I can also weigh in on COVID pandemic in terms of NTDs, but now in relation to excess mortality. Capture the excess due to NTDs because they never got treatment on time, or they never sought treatment, but they still died. But ordinarily they would not have died if the pandemic was not there. So apart from the other setback of control, surveillance and all that, we are also keen on excess mortality, and probably we'll have a bit of projection with the data for 2020 and 2021. Now with the concluding remarks, I think from our discussions, we have areas of collaborations. We have had and identified the gaps. We are good with the speakers and the forum. So I think this platform, we can create linkages where we can collaborate and continue carrying out research, whether basic, applied, or operational. And I think we are not going to lose this, because what is coming out clearly is that we have not won the war yet. We have a long way to go, and especially to ensure that beyond 2030, what will be the status of the NTDs. And then with the mass drug administration, where it is applicable, I think these have had a very positive effects. But with those disruptions, we are hoping that this can be fast-tracked. For example, in Kenya, what we have is these are targeted to the school-age children, and now with the lockdowns, the children were out of the school. So I am trusting that this can be fast-tracked and the effects can be reversed, because if we have temporary disabilities and we have permanent disabilities. So I hope that with the delayed drug administration, we are not going to go to permanent disabilities. So that is my concluding remarks, and I want to thank all the participants, the speakers. Professor Olivier, thank you for inviting yourself and for being such a wonderful chair. Thank you so very much. I look forward to more of these webinars. Thank you, Henry.
Thank you, Josephine. Thank you for your wonderful concluding remarks. So this is our third session, and we are going to concluding this webinar. So I would give time to our chair, Professor Olivier Sparagano, to give the concluding remarks for us.
Well, I don't know how we can conclude, but I think we should not conclude. As Josephine said, we should continue the fight. So let's not conclude the fight, but let's continue the fight. As colleagues are putting in the chat room, If some of you are interested to publish in the special issue, by all means do so. It will be free, so take the opportunity that the journal this year is very kind to let us publish for free. Let's take the opportunity. Maybe at one stage, as some colleagues said, and Josephine, we want to do something again next year and see how we are progressing and see if the journal, One Health and Implementation Research, wants to do a similar webinar next year and see if we have progressed and compare year on year. What are the new trends? Like, for instance, what I've discovered this year was amazing, and I think there are more to discover. So the ball is in the court of all the participants and the journal. If you want us to continue, there is room for work together. As we have seen, there is such a diversity of problems. If we don't work together, we are just going to create one treatment, one diagnostic for one disease, and I don't think that's going to be enough to win the battle. So we need the new generation. So I'm delighted to see you have created these youth editorial boards. We need also the new generation of publishing scientists, new generation of reviewers. So good on you at the journals to create that. I've not seen that in many journals, that there is a youth editorial board. So we need also to attract the new generation. It's too late for me, but I'm sure there are young people in the room that want to work on this problem for the next 30 years. That's not for me, that's for you. Thank you. Thanks to the journal, thanks to the speaker and the participants, and all the best wherever you are. And stay safe.